Thank you very much for being here. So this is a panel about preventive medicine and occupational medicine. I'm Maria Mora Pinzon. I'm a chair of the American College of Preventive Medicine, and it's my pleasure to have our two panelists today. Dr. Margaret Hasek, she's a program director of the University of South Carolina Preventive Medicine Residency, Dr. Aisha Rivera Margarin, who is program director for the Johns Hopkins Occupational and Environmental Medicine Residency. And I think many of the med students are probably watching this recording. This is the first time ever that you're hearing about these two specialties. And let me start by saying, yes, they're real. Yes, they're board certified. Yes, you are a full doctor and you get your license. With that out of the way, they're slightly different and there are unique residency programs for each of them. So I would like to invite our panelists to tell us what's preventive medicine, what's occupational medicine, and tell us about what type of students should even think about this specialty.
Sure. Would you like me to go first?
I think we can sort of maybe start with preventive medicine and then talk a little bit about occupational medicine, or just maybe give a broad overview of what's like the American Board of Preventive Medicine, and then talk a little bit about general preventive medicine, occupational medicine. And even if we don't spend a lot of time talking about aerospace medicine, since neither of us are in that particular field, we can at the very least kind of touch on it, and any students who are interested in it can always look for more information. Does that make sense?
Yes, certainly.
Sounds good.
So I think, Maria, like you had mentioned, we are different subspecialties, but all is under the American Board of Preventive Medicine. And so I will speak to the general preventive medicine and public health subspecialty. So we are a group of physicians that specialize in health promotion and disease prevention, which actually all of the subspecialties do, and we focus on various populations. So for us, we develop various competencies in our residents. And if anyone is interested in those competencies, I also recommend the ACGME. And you can look up the various subspecialties under preventive medicine, and that gives you a good in-look at the different competencies that we focus on in the different residencies. So for general preventive medicine and public health, we look at various areas such as community medicine, epidemiology, biostatistics, and then we also touch on competencies in some of the other subspecialties of preventive medicine, including occupational medicine, aerospace, toxicology. But we also focus on, again, health promotion, disease prevention, and health behavior. So our residents do have to have at least 10 months of direct patient care residency successfully completed before they apply to our program. And that's generally the case for most general preventive medicine programs. There are a few that do offer a PGY 1 year, but that is rare in the general preventive medicine program. So the types of residents that usually apply to our program are those that either have started another specialty and most commonly have just learned about preventive medicine as they started their residency, and hence, definitely wanted to join panels like these where we can educate about the specialty early on in medical education. And we're doing that even within our own home institutions, trying to educate about the specialty. We also try to be ambassadors of our specialty with the residents. So that's another competency area, is to be able to represent who we are in preventive medicine, what we do and what we can do, and how we can be useful and beneficial and important to our communities, our health system, and the patients that we serve. So the types of residents, going back to who usually applies, are those that either have started in another specialty and have learned about preventive medicine, or those that have completed an entire other residency and again, learn about preventive medicine and are very interested in population health. So not only that direct patient care that all of us physicians develop competencies in, but also kind of the aspect of population health and public health. So that's usually who applies to our programs. I'll stop there to give time to the other panelists.
Great. Thank you so much, Dr. Hasek, for covering that overview on general preventive medicine. So I'm going to go ahead and speak to occupational environmental medicine. I do have to give a little bit of a disclaimer that my opinions are my own and not those of my institution. This is being recorded, and I do have a Johns Hopkins background. So let me speak a little bit about occupational environmental medicine. It is a field that focuses on the health of workers and worker populations. So anything related to the diagnosis and treatment of work-related injuries and illnesses, as an example, would be the most straightforward way to think about it. But we also focus on how to prevent those conditions from happening. And if those conditions happen, not only do we treat them, but we focus on managing those conditions to prevent disability. So keeping people healthy in the workforce and making sure that workplaces are safe. And I think that's really the best way to describe the field. I'm sure others can think of better ways that I may have missed. What you can do with occupational environmental medicine is very broad. So you could do clinical care, which is what we think of when we think of a doctor, right? We all go to medical school because we want to have that component of direct patient care. But you could also focus on prevention. You could focus on research. You could focus on education. Really, I think it gives you an opportunity to take the driver's seat and really think about the possibilities that you can do with your career in medicine. So it really forces you to be an active participant because it's not always clear what path you're going to take. And I'm sure, Dr. Hasek, and if you talk to anybody who's in any of the specialties that fall under American Board of Preventive Medicine, you'll soon learn that they have very interesting paths. And so, it's definitely, I think, a little bit intimidating to think about when you're a medical student, especially if you haven't met that many folks who are in preventive medicine or occupational medicine. And you don't really know what that's going to look like in 15, 20 years. But we do exist. And I want to encourage you not to be afraid of making a decision to pursue a career in one of these specialties because you haven't met anyone. And I think that's part of the purpose of this panel to kind of increase the visibility of these public health specialties in hopes that students will become curious, and that curiosity will lead to folks actually pursuing these career paths.
And I think I would like now to hear, I like the message, Dr. Rivera, that you mentioned, that we don't want to discourage students on exploring their careers. I think the most common reason I hear is that I cannot apply as an MS4. I'm afraid of just applying for a prelim year, and then what if I don't match in occupational medicine, or what if I don't match in preventive medicine? So for everybody watching this recording, you cannot apply as an MS4 for these two specialties. You need to already have an inter-year, except for a few programs, but you need to hold them. And it's a process. But most generally, we get people as doing preliminary year, so maybe second year of some or another specialty, and they say, you know what, I want to do something else. And that's usually the people that apply. But then what would you say to a med student interested in our careers that's afraid of taking that leap of faith, let's say that way, of applying for just a 1 year program to apply to our specialties later?
Sure.
Yeah. Go ahead, Dr. Hasek.
I would say just, to really explore, I think we had mentioned to talk to, those of us that are in the field and just explore various career paths. And ACPM is really a great organization to do that. through, because that is the medical society and the specialty society for, the potential residency that you would be applying for if you're applying for general preventive medicine. But we also have not only general preventive medicine, folks with backgrounds in that subspecialty, but others as well. So I think exploring ACPM and just kind of networking and getting to know people's backgrounds can really solidify some visions and aims for your own career paths, even though they may not be defined as a medical student and kind of planning to do prelim year and then potentially applying to one of the American Board of Preventive Medicine subspecialties, but really just exploring and very early on. So these types of sessions are great because you can learn about, again, different options and kind of then get experiences. So once you kind of identify the areas of the preventive medicine that you're interested in, you can then kind of dig a little further, if you will, and talk to those that are actually, practicing in those areas or doing work in those areas, and then try and solidify your goals as you, apply for prelim year and then decide which of the preventive medicine subspecialties to apply to.
Yeah, and I think that's great. I would add, don't be afraid. I mean, I know that's easier said than done, but believe in yourself and your ability to make this work. You can plan on doing an intern year, a standalone intern year, and then you can apply to a PM2 position in either general preventive medicine or occupational medicine. And you can make yourself a strong candidate. I think if you make yourself a strong candidate, you don't have to be afraid that you're not going to get a spot necessarily. And I say that, I mean, I realize, there are no guarantees, but I think that, you should not be afraid to pursue this if this is what you want to do. And, the worst case scenario, if you signed up for an intern year and you didn't, get a spot in preventive medicine or in general preventive medicine or occupational medicine, there are other things you can do after that, and you can reapply the following year, right? So it's not like your time is going to be wasted. You could always build contingency plans alongside with your application process. So, don't feel like, oh, if I don't get in, it's the end of the world. No, your world is just beginning. And I think you need to take it all in stride, and that's part of life. And you can always reapply, or you can explore other opportunities that present themselves. But first and foremost, you're going to prepare yourself and make yourself the best candidate, and pursue opportunities to network and meet people in the field so that you can really become a subject matter expert and be able to speak to why you want to pursue either general preventive medicine or occupational environmental medicine. And once you have solidified, like you can speak to why you want to pursue either one, and you show that you're doing things that align with what you say your interests are, I think, you're going to be a candidate that anybody is going to want to have in the residency. So don't be afraid. My mom always says, del cobarde no se ha escrito nada. So you don't be afraid to be bold, but obviously do your homework. So.
Yes, and with that, I'll add, I think exploring the programs early on as well. If you feel like your path is geared towards doing, an internship year and then applying to one of the American Board of Preventive Medicine subspecialties, you could probably never start too early to explore programs that you may be interested in, and also comparing different programs and what they offer and what their rotation experiences are and who their faculty are and what their residents are doing. And then, again, expressing that interest early on, I think is positive. And then, like Dr. Rivera said about aligning your experiences with what you say you're interested in and why you think you may be a good fit for a program with, again, aligning with what they offer or what their residents are doing or what the majority of time, their residents are doing for training. Because again, the programs do differ a little bit in some of the different aims and mission of the maybe sponsoring institution, or whether it's through a health department or through a health system, whatever the setting is. So kind of doing that homework early, I think, is really beneficial, and expressing interest early is also beneficial.
And here I think I would like to add something. The programs are really different. So at least in preventive medicine, it's not like in cardiology or in internal medicine, you need to do 6 months of ICU and 6 months of this, 6 months of that. When I was exploring preventive medicine, it was different at every location. In some of them, here your clinic is going to be in the VA, and the other ones, no, your clinic is going to be a primary care clinic, or it's usually 2 months. The other one is going to be a public health department, and each one is going to build your connections and your career in a different way. If you want to work in public health, maybe a program in a public health department is going to give you better tools and strategies for doing that. But if you want to do research and academia and other aspects, maybe other programs with more scholarly support might be better. The programs are very, very varied, and I want to highlight that, as Dr. Hasek said. Some of them have specific aims, like our goal is to train physicians that are going to be in this location. And if that's not what you want, that's not a good program. And there's opportunity to explore. And I don't know if that's the same with occupational medicine. Dr. Rivera, could you tell us, are the programs very different from each other or same?
Yeah, so that's a good question. I think before I kind of dive into speaking generally about the programs, I think it's important for students to understand that funding for public health residencies is different than funding for non-public health residencies. So some of what ends up happening is that depending on who's funding the residency, they may have specific goals they want to see in terms of outcomes, the types of trainees and physicians like they want to see come out of that program. So occupational medicine residencies, most of them in the United States, are funded through a grant from the National Institute of Occupational Safety and Health that establishes education and research centers across the country to train occupational health professionals. So these centers are the home of where occupational environmental medicine doctors are trained, also where industrial hygienists are trained, where occupational health nurses are trained, just to give you an example. And so I think you'll find that by and large, even though there's going to be differences in where folks might do their clinical experiences or whatnot, we follow ACGME guidance. And so all programs are going to expect their residents or require the residents to do 4 months of direct patient care in each of the 2 years of training. Our program specifically requires the first year you're doing an MPH program within the School of Public Health. And then in the second year, we have 3 required 2-month rotations. One is with the International Association of Firefighters, which is a union that represents professional firefighters in both the US and Canada. So our residents are sort of the medical advisor for the union, and they get to see all kinds of interesting requests and inquiries about, whether or not an exposure at work may have contributed to a disease process. Most often the questions are around whether or not, the exposure contributed to somebody's cancer. There's mandatory rotation through the Occupational Safety and Health Administration, which is located in DC. And then we have a mandatory rotation through the University of Maryland and the Johns Hopkins Hospital. So our residents have an opportunity to understand how both systems approach occupational medicine. And then within that year, you're required to do the 4 months of direct patient care, but you have an option of where you do those months. So you have 6 months of elective time, and you can really sort of craft your own adventure. And I am very supportive of residents in terms of, whatever it is they want to pursue. If it's within, if it's, we can make it happen, we will do everything we can to make it happen. So we don't, as of right now, we don't require our residents to do a specific rotation because we're getting funding for that specific rotation, if that makes any sense, other than the ones that I've already mentioned. So there's a lot of flexibility, but there may be programs where you have a lot more requirements. And so those are things to kind of keep in mind. The other thing I think to keep in mind as you're looking at occupational medicine residencies is where they're housed. Some of them are housed within schools of public health. Some of them are housed within schools of medicine. And so that may affect or impact the experience that you have. And it's not necessarily that one is better than the other. They're just things for you to keep in mind because the dynamics may be different depending on where you go.
Thank you so much. That's a very important clarification, and I think of the funding sources. And I think that a lot of students think, why cannot I apply as an MS4? It's because of funding. Since we are not funded with Medicare, that's where it's not easy to secure that first year, and that's where we get into troubles. Dr. Hasek, anything you want to add on this part?
No, I think Dr. Rivera, came up, laid out very important points. Part of that was the MPH degree. So for medical students to be aware that, our program, I'll speak for our program, but in general, a master's level degree is required. And that doesn't mean that you have to come in with the degree. You can, and we do take that under consideration. But in our program, you obtain a master's of public health, and programs also structure that differently. Like Dr. Rivera said, in their program, they do their MPH in the first year. We have what's called a longitudinal curriculum where our residents, our graduate students full-time for the entire 2 years that they're with us, or 4 semesters if we look at the academic calendar. Similarly, I agree with the funding streams. I think those do impact many times the type of experiences that one may have in a preventive medicine residency. For us, we do have some funding from the Center for Rural and Primary Health Care. So we have developed some experiences with a rural health rotation. And then again, it has to do with the aims of the program. So we're within a large health system, and one of our aims is to retain graduates in the state and within our public health system. So that doesn't mean that if you join us, you have to do that, but that is one of the aims of the program. So just kind of asking those types of questions. Again, what are residents doing as far as rotation experiences? What are they doing postgraduate? What type of scholarly work are faculty involved in? What are their backgrounds? If you're interested in the MPH degree, perhaps you're limited to what type of classes you can take, and depending again on the program. And so if you're very strong in wanting, let's say to do your MPH epidemiology, it may not be an option in that particular program. So kind of getting down into those details of what may be a good fit for you and your interests as you consider different programs is very important.
And then before we go to the questions, and then the last thing, and this is the most common question that I get asked is, what do I need to have on my CV to be a good candidate? And for other specialties, sometimes they say, oh, you have to have 3 SOBIs in this specialty. You need to get 3 letters of recommendation from chairs of the departments. But for us, it's different. Or is it? What do you look for in the CV to say, this is somebody that I want to train?
For us, it's recognizing that a candidate understands the specialty they're applying for. So it's kind of the basics, and that they have an interest and have tried to align some of their experiences as a medical student with the specialty of public health and preventive medicine. So that doesn't mean that we're looking for, you know, candidates that have a complete background in the specialty. You know, we understand that, you know, these are medical students or other residents that are applying to the program, but we do look for some sort of path that the candidate has taken to get to know the specialty more, and they understand the specialty that they're applying for. And that's in a variety of ways, and these are highly encouraged. And part of that is just, again, talking to people in the specialty or physicians that have, you know, completed training or are working in the specialty. And then perhaps through organizational involvement, whether that's ACPM or ACOM or other. And again, it's not that we don't look at applicants that don't have that involvement, but when I see that, that lets me know that the candidate understands the specialty that they're applying for. And usually that is a little bit more elaborated on in the personal statement, and then, you know, perhaps recommendation letters. So we don't have any requirement that a candidate has to be involved in those organizations or has to have extensive, you know, public health experience or, you know, certain rotations in medical school. So we don't look at that to be eligible to apply. But I would say a candidate that has shown some knowledge and interest in the specialty that the candidate is applying for is likely a stronger candidate than one that, you know, lacks any evidence of interest or knowledge of the specialty.
Yeah, I think that's, I completely agree with everything Dr. Hasek said. I would substitute ACPM for ACOM in terms of involvement, but, you know, you could be involved with both, or one can lead you to the other. I think I would add, you know, that there's definitely some things that make some candidates stronger than others. So I can run through that list of what might make one candidate stronger than another candidate. But if you don't have all of these things, that doesn't mean that you're a weak candidate, and it doesn't mean that you're not going to get in. So I'll give you examples of what some individuals in program director positions may look for. I'm not saying that this is what I look for personally, but somebody who has completed a prior residency in something else, whether that's full residency in family medicine or another general specialty like internal medicine, is going to be a stronger candidate potentially for most program directors than somebody who's coming with just 1 year of internship. Now, that's not to discourage anyone who's coming right out of medical school, but I think that just speaks to having more time and experience under your belt. There are ways that you can develop time and experience without doing a full residency. So it's almost like having a full residency is a proxy for experience, if that makes sense to folks who are listening in. Again, I'm not trying to discourage anyone. The other thing, you know, candidates who have higher scores are typically going to be viewed more positively, say you, than somebody who doesn't. And there's a reason for that, right? When you finish residency, you're expected to take a board examination. It is in everyone's best interest, including your programs, that you pass that board examination. If you haven't done well on standardized testing in the past, it makes individuals in program director positions concerned that you may not do well on standardized testing in the future, or that there may be gaps in your knowledge that may be difficult to address or overcome during residency. So that's something for folks who are listening to sort of keep in mind. You know, it all kind of depends where you're looking, right? Like your perspective changes. Again, not trying to discourage anyone, just trying to give some examples of things that might make somebody a stronger candidate than someone else. And I think strong letters of recommendation. So if somebody has really strong letters of recommendation, it speaks volumes about them versus somebody who has maybe mediocre letters, or somebody who, you know, isn't able to get letters, or if there are other things that suggest that the person's going to have issues with their interpersonal skills, because a lot of what we do has to do with, you know, dealing with people and written communication and things like that. So, you know, you don't want to have someone who's going to have these issues and then, you know, is going to pose problems throughout, whether it's the MPH year or any of the rotations that follow. And so those are just some of the examples of things that will make you a stronger candidate versus maybe a less strong candidate. None of those things are things that you can't overcome. But I think, you know, if you can address all of those things and you're in the clear for all of them, then I think, you know, you're going to be in a better position. In addition to all the things that Dr. Hasek said, you know, showing interest and getting involved and having experiences that show that you really understand or have an idea of what the residency you're applying to will help you accomplish in your career.
Thank you so much. So I'm going to end the recording here. If anybody that's has any questions or anything that you would like to reach out, send me an email, find me on Twitter. All the information is on the organizers have it. So we're here to answer your questions, and I'd be happy to put you in contact with the fabulous panelists. Thank you.
Thank you.